like to welcome everyone to the 2020 Living with Cancer Symposium, Melanoma and Skin Cancer session. My name is Samir Patel. I'm a radiation oncologist at Mayo Clinic, and we were going to start off with introductions and just a brief introduction on about our respective specialties as well. So I'll start off with radiation therapy. Radiation therapy, as many have probably already experienced, is part of the spectrum of X-rays. You've probably received X-rays in the form of chest X-rays or multiple of different CT scans. Now, these are special X-rays that are given at a higher energy and are given to treat cancer. You may hear different terms like photon beam or proton beam or electron beam. And radiation therapy does play a role in skin cancer treatment for early stage and advanced stage skin cancers. For early stage skin cancer, radiation therapy can be an alternative to Mohs surgery or surgery in general, and it depends on the location of the tumor. The one thing is radiation is delivered in a series of treatments. And frequently for early stage skin cancer, the treatments are somewhere in the range of 20 to 30 treatments. For advanced stage skin cancers, radiation can be used in conjunction with surgery. And you may be involved with treating where the skin cancer is located, as well as where the skin cancer may extend along nerves or along lymph nodes. In regards to melanoma, radiation also can play a role but the mainstay is surgery and immunotherapy, but there may be a role for radiation as well. Now I'd like to introduce my colleagues too. To my left here, we have Dr. Wasif. If we can go ahead and have you introduce yourself.
Good morning. It's a pleasure to be here. So my role in the team for skin cancers is as the surgeon. We are surgical oncologists, as you heard Dr. Gray say just a little while ago. So we treat cancers using surgery, which is very simply removing the tumor wherever that may be. In melanoma, our role is to excise the tumor from the skin and often combine that procedure with something called a sentinel lymph node biopsy to check and see whether or not the tumor has spread from the skin to the lymph nodes. For early stage melanoma, for most people, that's about 60 to 70% of the melanoma diagnosed in the country, all you need is a good dermatologist, and they can perform the skin excision in their office as an outpatient. But once you move into the later stages, then the role of a surgical oncologist becomes more important. Also, for very late stage melanoma stage 4, there is also a role for taking out what we call metastases, tumor deposits in other parts of the body that are amenable to surgical resection, and combined with some of the newer therapies that you will hear about, that can actually be curative therapy even for patients with advanced malignancies. So the role of surgery expands the spectrum of melanoma, and we're involved in many stages of care.
Thank you, Dr. Wasif, for that great overview. Also, we have Dr. Seetharam joining us.
Hi, good morning, everyone. Thank you for the opportunity to be here and spending your morning here to hear about melanoma and skin cancers. As Dr. Patel mentioned, I'm a medical oncologist, which means I see patients when we need to consider giving some treatment, either before they have their surgery done, or after they have had their surgery done, or sometimes when the cancer is already spread to other areas of the body, when surgery is not an option or radiation, then we give some treatments which to treat the whole body with the hope that it controls the cancer wherever it is. So what is the role of treatment? I'm not calling it chemotherapy, because we have really walked away from chemotherapy over the last 5 to 8 years. Historically, if you look back 10 years ago, the outcome from melanoma was pretty dismal. because we had interferon, which is sort of biotherapy to help your immune system to fight it, the melanoma, but the treatment was really, really difficult to tolerate. Most of them would give up treatment halfway. So it worked only for about 5% of the patients. But fast forward to now, the outcomes have changed dramatically. I could even, that is an understatement, even dramatic is an understatement, because immunotherapy in the form where we know as it is been really very effective treatment to not only use before surgery, but also after surgery and for stage 4. You may hear about stage 4, which means metastatic melanoma. Historically, the 5-year survival before immunotherapy was in the single digits, 5 to 7% of the patients would survive beyond 5 years. And now, just as of a couple of months ago, that number is 52%. It has really turned the whole treatment paradigm upside down for a good way, in that the immunotherapy now is able to achieve a lot more than we ever imagined it to be, even with patients with brain metastases, when patients have been living beyond a year, which previously was 3 to 4 weeks. So immunotherapy in the form like Opdivo or Keytruda, you might have seen those advertisements on television, and there's a third drug called Ervoy. So we use either in combination or just a single drug by itself, which and all of those have been pretty effective. And also one other thing which has made a big difference is understanding the cancer better, the personality, because we need to really know what the genetics of the tumor is. The reason it is so important, it is half of the melanoma tumors have a mutation in a gene called BRAF, BRAF mutation. If you have that mutation, there are specific pill treatments which works extremely well and that too pretty fast to shrink the tumor. So it is important to have that information to help make the treatment decision. So what I want to say is, emphasizes treatment for melanoma in the last 5 years has really revolutionized the way we approach care these days, thanks to immunology, thanks to immunotherapy, and understanding the genetics of melanoma and the treatments we are able to harness because of a better understanding. Thank you.
Thank you for that great overview. This session is meant to be interactive with our attendees, and I'd like to open it up for Q&A. Please feel free to type in your questions in the Q&A box, and this is your opportunity to ask all of the specialists any questions. No question is a bad question. While we're waiting for questions, Dr. Wasif, when do you decide when you're treating a skin cancer to look at the lymph nodes?
So that's a very important question. And it's usually when we think that there's a risk of spread of the skin cancer, in this case melanoma, of 5% or greater. And there's been lots of studies to try and find, what makes you hit that threshold. And it really correlates with how deep the melanoma goes in the skin. Often when you think of a tumor and you are past the initial shock of finding out, well, yes, I have cancer, the next question that is intuitive is, well, how bad is it? And for melanoma, the how bad is it question is answered by the depth of the melanoma. How deep into the skin is it growing? Because the deeper it goes, the more likely it is to access what I call the freeway, which is your blood supply. And once it's in the freeway or your bloodstream, it can pretty much go anywhere in the body. That includes the lymph nodes. So the cutoff for spread to access to that freeway, spread to the lymph nodes, is a depth of 0.8 millimeters. And so when you get your biopsy report back, that is actually the threshold that we're looking at. If it's less than 0.8, it can be removed in the office and you do not really need to your lymph nodes examined. But if it's greater than that, then we do recommend a sentinel lymph node biopsy. That's how we check the lymph nodes. So that's one important criteria. The other important criteria is the presence of something called ulceration. That is when the surface overlying the melanoma is broken and it actually looks like a crater instead of a nice smooth surface. Ulceration, we know, is a marker of a more aggressive genetic makeup in that melanoma. So those are the two main criteria: ulceration and a depth of 0.8 or greater.
Oh, thank you for that insightful answer. We do have some questions come in. Let's start off with Dr. Seetharam. So the question is, what is the most common metastases from melanoma?
Thank you for the really very important question. So the one thing which I tell my patients is there is no site where you can bet against melanoma. I've seen melanoma anywhere, any organ you can name, even the heart. I've seen it in the heart. And the more common ones generally would be lung, liver, bones, not to forget the brain, because again, this is one such cancer which can creep up into the brain. So if somebody has been diagnosed with stage 4 melanoma, I generally would get a baseline MRI scan of the brain, not a CAT scan, but an MRI, if they can get MRI scan with contrast, because that is the most sensitive way to pick up any tumors within the brain. If they cannot get an MRI scan because of they have an implant or a defibrillator or an aneurysm clip or something, which is contraindicated, then we can get a CT scan with contrast. That's the next best option. So any organ can get involved with melanoma. So I would get a whole body PET CT scan. That would generally pick up wherever the cancer is hiding. Again, the scan sees only the scan can see. So we cannot rule out there could be some isolated clusters of cell hiding somewhere because the technology is not so sensitive enough to pick up the tumor cells per se, unless they grow to a certain size. So hopefully that'll be something in the future where we can detect those in the blood. But with the limitation of what we can do at this point, a PET CT scan or a brain MRI scan, which will be complementary generally, because the PET CT scan is not a good test for the brain. That is something we need to all really hear, because PET scan does not have this resolution to be able to pick up small tumors in the brain. So you need to get a brain MRI scan, because when you talk about melanoma in general, the risk of brain metastasis spreading to the brain is about 10%. But if you talk about stage 4 melanoma, say you find a melanoma which is in the lung or the liver, then that risk of going to the brain is about 40 to 50%. So you really need to make sure you get a good look at the brain when you're diagnosed with melanoma, especially stage 4 melanoma. So a PET CT scan along with a brain MRI scan at the minimum would be what I would recommend.
Thank you. There is a number of questions on immunotherapy, Dr. Seetharam. So one question is, are you seeing a shift to do immunotherapy with earlier stage patients? I was diagnosed with a stage 2A, clear sentinel lymph nodes, and 5 years later found out it metastasized.
That's really a wonderful question. Thank you for asking. That really brings up a very important point we should discuss. So whenever a new drug is being studied, the FDA requires it to be evaluated in patients who have advanced disease, wherein we can measure the benefit or lack thereof. That's what leads to the approval of the drug. So once that is confirmed, then they move it up to the earlier stages. So that is exactly what happened with immunotherapy with Keytruda and Opdivo and Yervoy. It was studied in 2011, 2012 in stage 4. Then Yervoy was, which is ipilimumab, which is an anti-CTLA-4 antibody. That was studied in stage 3, and that got approved for stage 3. And then the next wave of drugs came along, which is Opdivo and Keytruda, which are called anti-PD-1 checkpoint inhibitors. basically they remove the negative effect on the checkpoints, which controls the immune system. Because if you think about the immune system, it is basically there to identify any insults to your body. It may be an infection or inflammation or cancer, whatever it might be. Immune system rushes to the spot to take care of the problem. They're the first responders. So when you have that, and the immune system knows very well, it's smart enough to curtail its activity. It goes there, takes care of whatever needs to be done, and with minimal collateral damage. So if you envision a scenario wherein that does not happen, the immune system can just go without any check and balance, and it can start damaging your own cells. That is called autoimmunity, meaning you're affecting other healthy cells. That is what happens when you get immunotherapy, or that can happen when you get immunotherapy, because that is why you have side effects like diarrhea and inflammation of the skin, inflammation of the liver, so on and so forth. So when you get to that earlier stage, so when the checkpoint inhibitors were studied in stage 3, and they were found and compared, one drug was compared, which was Opdivo, was compared against Yervoy, because Yervoy was already approved for this situation, and Keytruda was studied against placebo. And both of those trials were positive, meaning they cut down the time to recurrence. So it prolonged the time from having had surgery and no evidence of melanoma to it coming back. It decreased the risk by about 50% using this checkpoint inhibitors. It delayed recurrence. And then some people, it did not ever come back because their risk was low enough. It did not really matter. So that brings us to an important discussion about what is the risk of a melanoma coming back. So if you go back to stage 3, there is stage 3A, B, C, and D. Stage 3D was not present in the earlier classification and staging of this melanoma. It is new since 2018. The reason is stage 3D, again, bigger tumors and lymph node involvement, they had a much higher risk of it coming back. So at 5 years, their risk of coming back was about 80%. But if you look at stage 3A, which is the small tumor, but still positive lymph nodes or in-transit metastases, their risk of it coming back is about 30% at 5 years. So the risk difference between stage 3A and 3D is quite huge. That is why most of these trials, they looked at stage 3B, C, and D, and it worked and it got approved. So, and then subsequently stage 3A was studied with Keytruda, and that also showed the same benefit, and that also got approved. Now the question is what to do with stage 2. You know, stage 2, generally they do much better than stage 3. I'm saying in general because stage 2C patients, you have stage 2A, stage 2B, and stage 2C, again, based on the cancer size, as Dr. Wasif referred to. Stage 2A patients, their risk of it coming back is probably somewhere in the range of 10% at 5 years. But patients, their risk is almost 40%. So if you remember what I mentioned about stage 3, stage 2C patients have a much higher risk of the cancer coming back than stage 2A patients because of the tumor size. That is why Dr. Wasif mentioned that the thickness of the tumor is very important, because that might change your thinking. And that for the very reason, there was a clinical trial done within the last 2 years looking at high-risk stage 2, which are considered stage 2B and stage 2C. These are considered the high-risk stage 2 melanomas. And those were studied in that clinical trial using Keytruda immunotherapy. And that is, we don't know the final results yet, but it'll be very likely to be positive, meaning it'll decrease the chance of those cancer coming back. So I don't have the final report yet from that trial, but many of the insurance companies, when I've asked them for approval for stage 2C for Keytruda or Opdivo, they have not denied it because they know the risk is high. So yes, to answer it, sorry, it is a long-winded talk, but basically what I'm trying to say is stage 2C, definitely I would consider doing adjuvant therapy if the insurance would allow, because we don't have the published data yet. Stage 2B, maybe, but again, there are no data yet. Stage 2A, I might not do immunotherapy because the possibility of being cured is pretty high with upfront surgery.
Oh, no, thank you, Dr. Seetharam, for that quite detailed answer. You answered all the immunotherapy questions here. Dr. Wasif, I'd like to, if you don't mind elaborating on the response you have for, this is a question. My daughter had melanoma at age 18 on her arm, no lymph node involvement. She sees a derm, but should she have cancer blood tests once a year, or what sort of follow-up? She's 10 years out. How likely is it recurrence?
So you just heard the statistics for recurrence depending on the stage. So it sounds like from the information you've given us that she's definitely not stage 3, which is great, but we don't know whether it's stage 1 or 2. But a couple of things to clarify. So for one, there is no good, reliable, or validated blood test for melanoma. There's several that are undergoing study. You hear about things like circulating DNA, but nothing that has made it from the bench to the bedside, the way we like to put it. There are tests for other types of cancers like colon cancer, but not for melanoma, and one is not routinely used or recommended by physicians who treat this. Your daughter is 10 years out. That is excellent. We do know that the longer the time between the initial diagnosis that passes, the less the risk of recurrence. And you will hear us talk about 5-year survival. For oncologists, 5 years is kind of like a landmark time, a milestone, because we know that for the vast majority of cancers, once you hit that 5 years, your chance of a recurrence is quite low. Now, it's important to note it's not 0, but it is less than 5%, I would say, or so, especially if she had stage 1 cancer to start with. Now, in terms of follow-up, what is important is that she continues to follow up with a dermatologist. And the main reason for that is that her risk of a second new melanoma elsewhere on the skin is actually about 7%. If you think about it, our skin is actually one organ. It's in fact the largest organ we have. So if she had melanoma in one part of the organ, the rest of the organ still has that predisposition. And so I think the best thing in terms of follow-up that we would recommend for your daughter is to make sure that she continues to follow up with her dermatologist. And right on cue, we actually have our ace dermatologist who's joined us to elaborate on that.
Well, first, thank you. And sorry, I was in the clinic, so that took a little longer. Seeing dermatology patients. So I think the question was about, maybe if you can rephrase the question for me, Nabil, that would be good.
Yes, I think it's a question that comes in from a concerned mother whose daughter had melanoma at the age of 18 with no lymph node involvement. And she had a twofold question. One is, should she have any cancer blood tests? And I told her there really isn't a good reliable one for melanoma. And the second one was related to what kind of follow-up she needs. And she's 10 years out, she mentioned that.
Yeah, so I suspect you already answered most of this. I'll start with the last part with the 10 years out. We typically see that if melanoma recurs, it recurs most likely within the first 2 years. And as further you go out, the less likely it is that it would recur. Having said that, we also know that if a person has one melanoma, statistically speaking, they're at higher risk for a second independent melanoma starting somewhere on the skin. Right. And so for that reason, it would be good to make sure that any person in this situation does self-exams, that they're very vigilant about following their own skin, but also having regular exams in the clinic that somebody can actually look and make sure they are taken care of. In terms of testing, I agree. There is not much in terms of testing that should be done at this point for the melanoma that was treated 10 years ago. Is there something else that one could do? Let me preface this by saying there are emerging things. And what I mean by that is, having melanoma at an early age, and 18 is an early age, the question always is there potentially a genetic predisposition? And that is a difficult question, has been historically difficult question to answer, because it wasn't easy to answer that question, and technology was not there. At this point, the game is changing significantly, and there are multiple ways to do this and screen for known genes that have been implicated as linked to cancer, including melanoma. And just as an illustration, we have recently completed a study looking at 3,000 different cancer patients that were offered this test to look at those cancer-causing genes. And there is a higher proportion of people with cancer, even without any family history, that have genetic changes that are likely linked to their cancer. And this is a new knowledge that's just now in print in one of the most prominent scientific journals. But it is something that is very quickly extending into practice, and something that could be considered in this scenario as well. However, every time one is thinking about genetic testing, this is not something that should be taken lightly. So I would strongly recommend always meeting with a genetic counselor, walking through pros and cons of genetic testing. Why would one do it? Why would one not do it? What would you do with the results once you get them? So those are very, very important questions to be able to answer and be confident that one knows why they are doing it. But that is something that potentially could be considered in this scenario.
Yes, thank you, Dr. Sekulic. There was questions earlier about prophylactic therapies to prevent recurrence, and Dr. Seetharam had gone into a great detailed explanation regarding immunotherapy and when that's indicated in the after surgery. On the dermatology side, are there any prophylactic therapies that could be used to not only reduce risk for melanoma or just other skin cancers in general?
Yeah, the most effective prophylactic therapy is sun protection, tongue in cheek. But it is true that a vast majority of skin cancers are related to sun exposure. And it is very, very important to emphasize how critically relevant continued sun protection over time is. This is really an investment that pays dividends over the long periods of time. And one may say, and I hear it often in the clinic when people say, well, the damage has been done. I've already been in the sun, growing up and so on. Damage is never fully done. It always expands. So sun protection is by far the most important. When we talk about any other therapies as preventive, early therapies for skin cancers, there are differences between different types of skin cancers. So when we talk about melanoma, there really isn't anything that we can recommend that we know will decrease the chance of melanoma in somebody who has had a lot of sun exposure, other than monitoring and early intervention. However, in other types of skin cancers, there are certain things that can be done, and those are things that are best done under the supervision of a dermatologist. For example, people will sometimes have other skin cancers, including basal cell carcinoma or squamous cell carcinoma. And some people with squamous cell carcinomas will have precancerous versions of squamous cell carcinoma called actinic keratoses. And in those scenarios, we will sometimes do what we call field therapy, which is really treating the precancers to prevent the full-blown cancers, sort of a secondary prevention. So the seeds are already there, but the tree has not grown yet. So that's the way to prevent it. And that can be done either with types of creams that can be used in areas that one is trying to protect, or with light therapy, such as photodynamic therapy. And in some patients, when there's significant numbers of skin cancers, even oral therapies will sometimes be used. Some of those are over the counter, such as nicotinamide, which is over the counter that people can take. And sometimes it includes derivatives of vitamin A that we sometimes use with people that have had numerous, say, squamous cell carcinomas to prevent or minimize the chance of new skin cancers.
Excellent, thank you. Dr. Seetharam, while we're waiting for more questions here, could you touch on immunotherapy for non-melanoma skin cancers?
Thank you, Dr. Patel, for asking that. So if you think about immunotherapy, it seems like it should be in the water. Everybody should be just drinking immunotherapy every day. That's what it seems like, because right now there are about 15 different kind of cancers where an immunotherapy has been approved, starting with melanoma, which is the poster child, and the list goes on: stomach cancer, kidney cancer, bladder cancer, lymphoma, and so on and so forth, head and neck, lung cancer. So the reason is, again, it all comes down to the tumor, comes down to what's in the tumor, because there are a few things which can predict your response to immunotherapy. And it doesn't mean that's a slam dunk, but it at least gives us an idea if somebody might respond to immunotherapy. And so what are those things we are looking for? So one is what we call as a tumor mutation burden, meaning how much of the cells in the tumor has some kind of a genetic change, what we call as a mutation, is abnormal. That abnormality, what gives the survival advantage for cancer cells, because then the immune system has a little difficult time trying to identify the rogue cells. So the higher the tumor mutation burden, the greater the response of immunotherapy try to fight it. They're trying to fight it. They may be ineffective, but they're trying to fight it. So the higher the mutation burden, the immunotherapy works better. In fact, a tumor mutation burden there is a cutoff. If it is less than 5, it's called low. From 5 to 10, it's intermediate, and over 10, it's high. Recently, the drug called Keytruda was approved just for the high tumor mutation burden. It doesn't have to depend on any particular type of cancer. It could be any cancer. As long as you have a tumor mutation burden of over 10, you can get Keytruda. That's something new. We call it as a tumor agnostic therapy, meaning to say it doesn't depend on the type of tumor. If you have it, you can get it. So the second one is called the PD-L1, which is called the programmed death ligand. It's like an antenna which is present on the cancer cell. So the immune cells are trying to look for that. If you have a high PD-L1 expression, then the immunotherapy is likely to work well. And the third component is called microsatellite status. This is, again, a sort of a technical term which relates to the cancer cells. What we call the microsatellites is a genetic component. If you have an instability in that microsatellite, which is measured by different proteins, then that also lends itself to benefit from immunotherapy. Cancers intrinsically, as Dr. Sekulik pointed out, most is sun damage. When you have sun exposure to the skin, there's a lot of DNA damage going on every day. So that DNA damage leads to high tumor mutation. And that mutation also leads up to high PD-L1. So it's a self-fulfilling prophecy. So higher the mutation, higher the PD-L1. So that's why immunotherapy has found its way in treating pretty much a lot of different skin cancers. Once melanoma was approved, and then squamous cell cancers of the skin have been approved for immunotherapy treatments. And Merkel cell carcinoma, which is an aggressive type of skin cancer, is also been approved for immunotherapy. So pretty much we treat any of this immunotherapy, skin cancers with immunotherapy. And for melanoma, it works very well. For Merkel cell cancers, it works very well. For squamous cell skin cancers, it works okay. Again, not as good as the other two, but certainly the FDA has found it beneficial enough that it approved for squamous cell skin cancers with drugs called cemiplimab. You may have heard about Libtayo. That's a drug which is specifically studied in squamous cell cancers, and that is where the approval was granted for squamous cell skin cancers. You could use Opdivo, you can use Keytruda, but those trials were not specifically done for squamous cell cancers of the skin, but cemiplimab was done specifically for skin cancers, squamous cell skin cancers. So we could use any of these immunotherapy drugs in any of these 3 skin cancers.
No, excellent. Thank you. On the line of exciting new therapies for skin cancers, Dr. Sekulik, would you be able to touch on the exciting work that led to FDA approval for advanced basal cell cancers?
Sure. As we think about skin cancers, there are two, I guess, that are most common, and that would be basal cell carcinoma and squamous cell carcinoma. In fact, they are so common that um, the government does not require strict reporting for these cancers as it is required for all other cancers. So the numbers of these cancers per year are estimated rather than recorded very accurately. But the estimation of numbers of basal cell carcinomas per year in the US is about between 2 and 4 million. That would make it a higher number than all other cancers combined per year. Fortunately, the vast majority of those are treated by very simple surgical procedures, sometimes even with topical types of immunostimulatory medications like Aldera or similar. But some will progress to a point where we call them locally advanced. And in rare cases, even metastatic basal cell carcinoma, meaning the basal cell carcinoma that spreads from the skin to other organs and can be deadly. Historically, for those patients that have had more advanced versions of basal cell carcinoma, we really didn't have much in terms of treatments other than surgery and radiation, which work well when they do, but if they don't and the cancer keeps recurring, that's the issue where we didn't have a good answer. There is a long but very interesting story of discovery that led to identification of mutations that drive basal cell carcinoma. And it turns out that unlike many other cancers, like melanoma, where there may be different mutations that drive the cancer, in basal cell carcinoma, it seems that it's always or almost always one identical switch that's broken in the cell by those mutations. So that really prompted a race to identify or develop a drug that could turn that switch back off, and in that way treat basal cell carcinoma. And that really, that switch is a relay of signals, which is called hedgehog signaling pathway. And the drugs that were first developed for this really were developed and designed to essentially flip that switch back to the off position. And they do work in vast majority of people where those drugs are given. The problem is, one, that there are significant side effects with these drugs. And those side effects are such that long-term use is really not feasible. And that is what's limiting the use of these medications. But still, in those patients where there's no other options, this is one of really wonderful options when it works. Two, in addition to having all those side effects, the medication does not work equally well in all cases of advanced basal cell carcinoma. So some people will clear and stay clear, and some people will not. And then in those that clear, there's also a proportion of those that will redevelop the disease. And so when you combine all this, you can see that there are some challenges. But nevertheless, I think in the right scenario, these drugs can be very helpful. And we have treated many patients with these types of medications. But as I said, not everybody benefited, especially not long-term. And that realization of the lack of long-term clearance and the success of immunotherapy in other fields has led to studies of immunotherapy in basal cell carcinoma. And we're just finishing a study at this point of cemiplimab that was mentioned earlier by Dr. Seetharam, which is an immunotherapy used in melanoma or used in squamous cell carcinoma. Now we're completing a study of that drug in basal cell carcinoma. So that would be for patients that have not benefited from a hedgehog pathway inhibition with previous medications.
Well, thank you. We have a question here that's just come in. So, patient that had melanoma 27 years ago and had a squamous cell cancer treated with Mohs and several basal cell carcinomas. Currently undergoing chemotherapy for non-Hodgkin's lymphoma with R-CHOP. Looks like there's another skin cancer that it may be biopsied and surgery may be recommended. Is it okay to proceed with this type of surgery during chemotherapy treatment? Dr. Wasif, you gonna take that?
So based on the information we have, I'm going to guess that this is probably either another squamous cell or a basal cell. And I think the short answer is yes. You know, I think you can have what would be considered a relatively minor, usually an outpatient office procedure to address this, and not have to significantly interrupt your course of chemotherapy for lymphoma. And I'll be, interested to see what everyone else on the panel thinks as well.
Maybe I can chime in. I think I agree with this, but it's all context dependent. You know, what type of skin cancer is it? What stage, how advanced, what does it require in terms of surgical and possibly other treatments. But also, I think it always is good to coordinate with your oncologist that is treating you with R-CHOP. You know, if there is a reason to think that there may be increased risk of infection or something like that, and the surgery for the skin lesion could be postponed, that all is possible. So really having a team that works together, your dermatologist and your oncologist, I think is the best approach.
Yeah, so I agree with whatever has been said so far. So from thinking of as an oncologist, again, this sounds like a simple outpatient procedure, which doesn't concern me as much. But if there is any bigger surgery planned, I would certainly time it well with regards to chemotherapy, because R-CHOP is a very effective treatment for lymphoma and very good outcomes. So you don't want to jeopardize the treatment for lymphoma. So, but R-CHOP is also a combination chemotherapy which can suppress the bone marrow, and it can decrease the white cells. Again, the longer you go on R-CHOP chemotherapy, the longer it takes for the bone marrow to recover. So unless you're getting Neulasta, which is a white cell booster shot with each chemotherapy, which hopefully prevents that complication of decreasing blood counts, generally the best time to have these simple procedures done is the third week, which should be the week leading up to the next chemo, because your white count would have recovered by then. So, but certainly good to check it before anything is done, because to avoid any risk for infections. But it should not be a big problem with a simple outpatient surgery.
Excellent, thank you. Well, we don't have any more pending questions. We haven't, would any of the panelists like to offer any other thoughts?
So I think, for several patients, I bring this up because they're often asked me about sun exposure, and we heard Dr. Sekulic go into that a little bit. I think it is also important to distinguish between acute and chronic sun exposure. And what I mean by that is, if you look at your typical farmer who's out in the field all day without their shirts, for years on end, they get a lot of sun exposure, but they get it over a long period of time. So they typically don't actually get melanoma. What they're predisposed to is more the squamous cell and the basal cell tumors. And because the time of exposure is so extended, that is probably the reason why these tumors have so many mutations, because they have that time to develop these mutations. Whereas on the other hand, where you have acute sun exposure is typically you go out in the sun, you're on the beach, you get 2 or 3 hours of intense exposure, and you get a sunburn. And the kind of sunburns that we think predispose you to the subsequent development of melanoma are usually those peeling sunburns, where you're actually having blistering and peeling off the skin. And particularly when you're younger, in your teenage and the early 20s, that's a particularly vulnerable time to get these peeling sunburns. And the subsequent development of melanoma doesn't happen right away. We see this from epidemiological studies that they start appearing 2, 3, 4 decades later. And so, especially in the United States, if you look at the incidence of melanoma, it is going up in almost a direct, steep increase. And we think that's because the baby boomers, as they're getting older, They're starting to see the effect of this acute sun exposure that they had in their youths when, we really didn't appreciate this correlation. In fact, people were out putting oil in order to get sunburnt and in order to get those peels. And we now know that is very, very harmful to the skin. So I just, interested to get everyone's thoughts on that, because I always thought that was fascinating, that acute versus chronic actually manifests in different ways.
Yeah, maybe I can add to that. I think this is something that we know from very clear epidemiologic data, looking at what kind of sun exposure people have had. This has been questioned because people would say, well, maybe those that have melanoma, maybe they're thinking more and they're remembering more their sunburns. But since then, there has been enough data coming out that I think we can safely say that yes, high level exposure is correlated with high risk for melanoma, which does not mean that it's the only type of exposure that matters for melanoma. As you can imagine, if you're going to want to ask a question, does 20 years of sun exposure after your sunburn matter? You need to do a study that's 20 years long, and nobody does those studies except Australians. And so they have done actually a very, very nice study that I think it took 23 or 25 years, and really demonstrated that additive sun exposure can further increase risk for melanoma. But as Dr. Wasif was mentioning, the other skin cancers are more related to chronic sun exposure, particularly squamous cell carcinoma. Whereas with basal cell carcinoma, there's probably a mixed bag of exposure that can lead to that. So I think we should probably use this opportunity to talk a little bit about sun protection. And it is really sad to see how little attention has been paid to sun protection, from playgrounds in kindergartens and schools that are not covered, to the fact that sometimes kids are not even allowed to use hats during their recess. I guess I'm talking about pre-COVID times, but not allowed to use hats for various reasons. Whereas in countries like Australia, where they have made significant gains against skin cancer, particularly melanoma, kids cannot go on a school trip without a hat that also covers their neck. And in fact, those are available everywhere, from grocery stores to every convenience store. So much, much higher level of awareness that probably can be contributed to a campaign that was run in Australia some couple decades ago. So it is important to sun protect. And what sun protection means is not just saying, I do not lay by the pool. The sun doesn't care whether you lay by the pool or you're standing in your driveway in the middle of the day talking to your neighbor for 30 minutes. It's the same sun. So really, sun protection includes avoidance of the sun when you can do things and choose to do them when the sun is less intense. It includes physical protection, meaning shade. If you can be in the shade versus in the sun, choose the shade. It includes clothing that is long sleeve clothing when possible, when feasible, as well as a hat. And the hat, ideally, broad brimmed hat should be used. It's much, much better than the ball cap. And then anything that's not covered, one is encouraged to use sunscreen. And we do get a lot of questions about what type of sunscreen should I use. There is no hard and fast rule, but the general principle is the higher the sun protective factor, or SPF, the better. Typically, American Academy of Dermatology will recommend anything of SPF 30 or higher. There are studies showing that higher SPF, even above 30, is better. And it may be better for multiple reasons. One, people don't apply as much as when these are tested. We don't apply it evenly, so you have areas that are better or less well covered when you apply it. And more sunscreen with higher SPF probably lasts a little longer. Because it gives you a bigger buffer there. So high SPF, look for sunscreens that are labeled as broad spectrum, UVA and UVB. And then particularly be sure to use enough of the sunscreen and be sure to reapply it. Even if you're not perspiring and going into the water, the sun rays, ultraviolet light rays, will degrade molecules of sunscreen over time. And with time, you have less and less protection. And final thing is, if you are perspiring, if you are going into the water and out of the water, you should use sunscreen that is labeled as sweat and water resistant. And nowadays, this is mandated to be labeled with the length of resistance, with the longest allowed label being 80 minutes, meaning after 80 minutes, you should be reapplying, especially if you're going in and out of the water.
No, excellent, excellent. That's great advice here, particularly for Arizona. There is one final question here. This one for Dr. Sekulik. Does the condition seborrheic keratosis predispose one for malignancies?
Thank you for that question. So seborrheic keratosis are a fascinating growth on skin. And I say fascinating because they are, to some extent, very similar to squamous cell carcinoma. Squamous cell carcinoma really is thickened and disordered growth of the top layer of the skin. Same happens in seborrheic keratosis. Seborrheic keratosis also contain mutations, and we know that those mutations are likely linked to growth of seborrheic keratosis. However, seborrheic keratosis do not progress. They do not turn into squamous cell carcinoma. They do not turn into melanoma. So in themselves, they're really benign. The only thing is that sometimes they get irritated, and sometimes chronically irritated, and that can be annoying for people. But in themselves, they don't pose any danger. How they're treated mostly on a cosmetic basis. And unfortunately, there is no simple treatment that can melt or take away seborrheic keratosis. And I say melt because many people will walk in with 10, 20, 50, 150 seborrheic keratoses. Some families seem to have them more than others. So there's no really simple way to do this. Typically, those are either being treated by freezing, sometimes scraping or removal in a surgical fashion. But in vast majority of cases, this is done really for more of a cosmetic reason rather than medical reasons.
Excellent. You know what? I lied. There is one more question. This again for Dr. Sekulik. Someone's asking, I know we touched on this a little earlier, is if we're elderly, let's say 85, does the sun exposure you get today matter in terms of getting cancer from that exposure? In other words, how long does it take to get skin cancer from sun exposure?
That is a great question. And I just feel like my morning is repeating. I was just with a patient where I was answering similar question. I would say, yes, it does matter. And it's not sun exposure and then something happens after the sun exposure. Think of it differently. Think of your skin as a car, paint on the car. How long does it take for the car to rust? Well, when the paint is intact and the car is new, it may take a long time, right? I mean, you could leave it out in the rain for years. But if that car has been here in Arizona for a while and that paint has kind of peeled off and now you have spots where you have no paint, it's down to the metal. That car gets 2 sprinkles, 2 drops of rain, it's going to start rusting. So the skin is no different. The buffer that you're born with gets exhausted over time. And sometimes at some point in your life, it is really just adding that last drop in the bucket that makes it spill over. And it's really not a significant amount of exposure. It could be minutes that can make a difference. And for that reason, one could probably argue that the strict sun protection at an advanced point in time when there's a lot of sun damage is probably more beneficial than any time before that in your life.
That's excellent. I really like that analogy. I'm going to use that too.
Good.
Well, there are no further questions. I think we can wrap up our melanoma skin cancer session for our 2020 Living with Cancer Symposium. And also notice there is a 5-question post-event survey that's been posted in the chat. So encourage everyone to fill out the survey and you get a chance to win a Mayo Clinic cookbook.